Thank you, everyone, and we are returning from our break. We are happy to reconvene ACIP. We are moving into the next session on vaccine safety, and Dr. Tom Shimabukuro from CDC ISO will start us off and then give us an overview of where we're headed.
Thank you. So the topic of this session is going to be CDC efforts to study the safety of the childhood immunization schedule. Next slide. So I'll provide a background on the CDC Immunization Safety Office and ISO efforts to study the safety of the childhood immunization schedule. And then Dr. Matthew Daly is going to talk about the childhood immunization schedule and safety and studies in the Vaccine Safety Datalink. And then lastly, Dr. Anders Svid is going to describe an analysis on the preliminary evaluation of aluminum content in childhood vaccines and the risk of asthma in a Danish nationwide cohort. And then we'll have discussion. Next slide. So just some background on our office. The mission of our office is to monitor the safety of vaccines given to children and adults. Some of our key activities include monitoring newly recommended vaccines and new recommendations for existing vaccines, monitoring CDC priority vaccines, including seasonal flu and COVID vaccines, conducting planned safety studies, supporting the data needs of the Advisory Committee on Immunization Practices, assessing individual risk factors for adverse events, responding to vaccine safety inquiries, conducting communication and education, coordinating with state health departments, and preparing for pandemics and emergency responses. Next slide. And these are our main monitoring programs: the Vaccine Safety Datalink, the Clinical Immunization Safety Assessment Project, VSafe, and the Vaccine Adverse Event Reporting System. Next slide. So in 2013, the Institute of Medicine, which has been renamed the National Academy of Medicine, conducted a review of the safety of the childhood immunization schedule. And the Institute of Medicine, in this report that you see here, concluded that the available evidence supported the safety of the childhood immunization schedule. The IOM identified areas that warranted further study, and concluded that randomized controlled trials were not suitable for studying the schedule due to ethical concerns, but identified the Vaccine Safety Datalink as a resource to conduct observational studies on the safety of the schedule. Next slide. As a result of this report, CDC and the Vaccine Safety Datalink published the white paper, the VSD white paper. And in this paper, VSD identified plausible outcomes for study in the schedule, suggested methodological approaches for studies, and proposed next steps. Next slide. So I'm going to turn it over to Dr. Daly here to describe some VSD studies. But before I do that, I want to reinforce that CDC takes vaccine safety seriously, including the safety of the childhood immunization schedule. And that's demonstrated by our work in the Vaccine Safety Datalink and our continued efforts to study the safety of the schedule.
Hello, everyone. I'm Matt Daly, and I'm going to present now on the childhood immunization schedule and safety studies in the Vaccine Safety Datalink. Next slide. I have no conflicts of interest. Next slide. This is an overview of the talk that I'm going to give. I'm first going to review some additional aspects of the 2013 Institute of Medicine report that Dr. Shimabukuro made reference to. Then I'm going to discuss feasibility work within the Vaccine Safety Datalink, specifically the white paper. Next, I'm going to discuss briefly 3 published VSD studies. These have all been published, but they haven't been presented publicly at ACIP. They all examine various aspects of the schedule and then more long-term health outcomes following exposure to the schedule. Then I'm going to touch on future investigations, and then I'm going to try to put this into a little broader context. Next slide, please. So, as Dr. Shimabukuro said, In 2013, the IOM issued a report that was titled The Childhood Immunization Schedule and Safety. I would highlight that this IOM report was not done because of known problems with the schedule, but was done to respond to public concern. Parents had expressed the concern, the schedule seems to be too many vaccines too soon. And that was what drove the IOM to issue this report. The IOM solicited public comment, reviewed the literature for concerns, and then reviewed scientific evidence around the safety of the schedule. The IOM concluded that existing evidence supported the safety of the schedule as a whole. However, they identified a number of evidence gaps. One way to think about this is that there were no studies that randomized children to receive the entire current schedule or no vaccines. And those studies would not be ethical to conduct at this point in time. However, that presents certain challenges. Again, each new vaccine is just added to the existing schedule. In addition, the IOM highlighted several other aspects of the current evidence base, such that safety studies usually examine acute adverse events, and there's less known about long-term health outcomes following exposure to the schedule, and this was a concern that parents had raised. And then the IOM committee had a number of conclusions, some of which we've already made reference to, but that randomized controlled trials would not be appropriate in this context for ethical reasons. However, additional studies were needed in existing surveillance systems, in particular in the VSD, or Vaccine Safety Datalink. And then the methods for these studies was going to be complex. And because of that complexity, additional feasibility work was needed. As an aspect of complexity, what does it mean to be exposed to the schedule? Because again, it's not a question of studying a single vaccine given at 2 months, 4 months, and 6 months, but somehow can you examine the entire schedule, which represents multiple doses given over multiple times, as an exposure in a traditional epidemiologic study. And then finally, the Institute of Medicine recommended focusing on long-term outcomes. Next slide, please. This led to the white paper funded by the Centers for Disease Control, involved subject matter experts, CDC colleagues, and VSD colleagues. Just to explain a little bit more about the VSD, it's a collaboration between the CDC and integrated healthcare organizations, and it conducts vaccine safety surveillance and research. The objectives, Dr. Shimabukuro mentioned in his introductory slides, but an objective was to define measures of the schedule that could be studied with a focus on the first 24 months of life, in part because this was the primary age at which parents were expressing concerns, and then to identify plausible outcomes that could be studied in this context, again with an emphasis on long-term adverse events, not because there had been a problem that was raised, but because this was the area that parents were most concerned about. Then there was some additional consideration about methodologic approaches, and then the white paper group looked at potential outcomes and then prioritized those outcomes based on feasibility, public health significance, public concern. Next slide, please. Some additional conclusions from the white paper group included the following. Several high priority outcomes were identified, including allergic disorders such as asthma, autoimmune diseases such as type 1 diabetes mellitus, and neurologic disorders including epilepsy. It's important to note through this entire conversation that some public concerns may have limited biologic plausibility. That should be taken into account. That's not necessarily a reason not to ever investigate that hypothesis, but it's a cause for caution. The white paper group had some additional conclusions that there needed to be really careful attention to bias. This is true for all observational studies, but in this setting in particular, because under-vaccinated or unvaccinated children may be a different group than fully vaccinated children in a number of ways. So attention to bias, concern about unmeasured confounding, including misclassification bias. For example, do kids who appear under-vaccinated within the VSD, are they actually under-vaccinated? So there was a recommendation to conduct surveys of parents. This was done, and for the most part, confirm that kids who appear under-vaccinated in the Vaccine Safety Datalink are in fact under-vaccinated when you call their parents. Another recommendation was to use negative control outcomes. This is a way to detect potential bias in a study because this is an outcome that should not be associated with the exposure. So again, it's a way to detect potential bias. An example would be all-cause injury, which shouldn't relate to any aspect of the childhood immunization schedule. And then there was additional caution to make sure to control for differences in healthcare utilization between these groups. And then a final note of caution was to plan for a long and complex process. There was a recommendation that any initial positive findings would need to be studied further to refute or replicate initial findings. Next slide, please. So now I'm going to transition to review 3 published studies. The first is a VSD study of antigens and non-targeted infections. The public concern here was that early childhood immunization could overload the immune system. And then that needed to be converted into a testable hypothesis. The study design was a matched case control. The exposure was cumulative vaccine antigen exposure, estimated by summing the number of antigens in each vaccine dose, birth through 23 months of age. The outcome was infections, but particularly infections not targeted by vaccines in emergency department and inpatient settings, 24 through 47 months of age. So think about this in terms of the public concern. This is basically saying, do kids who receive the full schedule have more infectious illnesses later that aren't targeted by vaccines? In this study, a sample of outcomes underwent medical record review to validate those outcomes. Again, it's a matched case control, so there was matching on age, sex, and presence of chronic disease. Next slide, please. Here are the results of that study. Among children with versus without non-vaccine targeted infections from 24 to 47 months of age, the matched odds ratio for cumulative vaccine antigen exposure was not significant, with the matched odds of 0.94, confidence interval that included 1. There were a number of secondary analyses which were consistent with the primary findings. And so the conclusion was no association between the number of antigens young children receive through vaccines in the schedule and then the likelihood of subsequent ED or inpatient encounters for infections. In other words, there was no evidence this schedule overwhelms the immune system, at least overwhelms the immune system as defined by more risk of infection later. Next slide, please. So this is an additional study of the immunization schedule in type 1 diabetes. Here, the public concern was that vaccine antigens or ingredients, which would include aluminum, which is used as an adjuvant in vaccines, could interfere with immune function and, as a consequence, increase the risk of autoimmune disease. This was a retrospective cohort study. One thing that was unique about this study was that 3 different exposures, 3 different ways to measure the schedule were examined. Cumulative vaccine antigen exposure in the first 23 months of age, cumulative vaccine-associated aluminum exposure in the first 23 months of age, or average days under-vaccinated. This is a more complex and perhaps less intuitive exposure, but what this measures is vaccines given later. So it's essentially sort of a metric of delay. So 3 different exposures. The outcome was type 1 diabetes mellitus, identified by diagnosis codes. Diagnosis codes and electronic health records have a high degree of accuracy for identifying incident type 1 diabetes. The length of follow-up in this study was greater than 5 years as a mean, and then analyses were adjusted for a number of factors, including sex, race, and ethnicity, and other factors, including healthcare utilization as measured by the number of well-child visits. Next slide, please. Here are the results of this examination of the schedule on type 1 diabetes. In the main analyses, as I mentioned, there were 3 different exposures. Cumulative vaccine antigen was not significant. Cumulative vaccine-associated alumina was inversely associated, so a hazard less than 1, a hazard of 0.77, with a confidence interval that did not cross 1. And then average days under vaccinated was non-significant. There were a number of sensitivity analyses, including factoring in family history of type 1 diabetes, and those were similar to the primary results. So in conclusion, the vaccine schedule was not associated with an increased risk of type 1 diabetes. However, there was this finding that there was decreased risk of type 1 diabetes at a higher vaccine aluminum exposure. But I want to highlight that we need to interpret this finding. It's important to consider, but interpret it with caution because there's a modest effect size here, and there would be more study needed to either refute or replicate this finding. Next slide, please. Moving on to the third published VSD study presented in this context of studying the schedule and then more long-term health outcomes. This was a study of vaccine-associated aluminum and risk of subsequent asthma. The public concern here was that vaccine ingredients, including specifically aluminum, which is used in vaccines as an adjuvant to make them more immunogenic, could possibly increase the risk of allergic disorders, including asthma. There is some biologic plausibility, excuse me, to this hypothesis, although I describe the biologic plausibility as tenuous because it's based only on animal data. But there is some animal data that suggests that aluminum in vaccines could skew towards a T helper cell 2 or Th2 response, and it is known that Th2 cells play some role in allergic asthma. This study was a retrospective cohort. The exposure was cumulative vaccine-associated aluminum received birth through 23 months of age. And then the outcome was persistent asthma at 24 through 59 months of age. That outcome was defined as 1 inpatient or 2 outpatient diagnoses of asthma plus 1 or more prescriptions for a long-term asthma control medication. And then all of these analyses were done separately for children with or without eczema. And the reason for this is that eczema is a condition, chronic dry skin condition, presents in early childhood, and then is strongly associated with subsequent asthma risk. So the thought there was that it could be an important confounder because it could also influence vaccination patterns. So all analyses were done separately for children with and without eczema. Next slide, please. Moving on to the results of this study, there were more than 14,000 children in this VSD study with eczema. 6.0% subsequently developed persistent asthma. There were more than 312,000 children without eczema. 2.1% subsequently developed persistent asthma. And then the median vaccine-associated aluminum in these cohorts were both 4.18 milligrams. Next slide, please. So this slide, I'm going to go through a little more slowly because there's a little bit of complexity here. What this slide shows is the crude incidence rate of asthma by the quantity of vaccine-associated aluminum. The y-axis is persistent asthma per 10,000 person years, and then the x-axis is vaccine-associated aluminum in milligrams. I'll stop here and say, what explains variability in vaccine-associated aluminum? Essentially 2 things: under vaccination, kids not getting all the vaccines that were recommended for them, or differences in the vaccine products used. The left panel is eczema before 12 months of age, again, more than 14,000. And as you can see, and I said these are crude incidence rates, so it's with no adjustment for covariates. And as you can see, the asthma incidence appears to increase with increasing levels of vaccine-associated aluminum. The same is true for the no eczema cohort. It's a little less striking visually, in part because the y-axis is bigger because of the higher asthma risk among those with eczema in the left panel. Next slide, please. So this slide shows adjusted results, primary analysis. I'll walk us through this. First column is the variables, including a number of covariates. Second column is the adjusted hazard ratio for the eczema cohort. Third column is the adjusted hazard ratio for the no eczema cohort. I'll highlight that the eczema cohort model is a different model than the no eczema cohort. As I mentioned, the results are analysis are stratified. So for the eczema cohort, there's an adjusted hazard of 1.26 with a confidence interval that does not cross 1 for the risk of persistent asthma. For the no eczema cohort, the adjusted hazard ratio is 1.19, confidence interval that also does not cross 1. And then there are a number of covariates. These are all chosen because they are known risk factors or suspected risk factors for asthma, and these are all of a direction and of a magnitude that we would expect based on the published literature. And then there were additional covariates. Those are included in the notes below the table. Next slide, please. So on this slide, we're presenting a number of secondary analyses. Each row represents a different analysis. First column is the analysis, second column is the sample size, third column is the adjusted hazard ratio for the eczema cohort, fourth column is the sample size for the no eczema cohort, and then the last column is the hazard for the no eczema cohort. Again, each row represents a separate adjusted analysis. First row is the primary analyses, which I just showed on the prior slide. Second row, if we look at aluminum not as a continuous exposure, but as a dichotomous exposure, more or less than 3 milligrams of aluminum, adjusted hazard was significant for both the eczema and the no eczema cohort. Next row, if we exclude aluminum in the extremes, so if kids who got less than 1 milligram of aluminum from vaccines or more than 5, they may be very different than the rest of the cohort. So if those are excluded, results are significant both for the eczema and the no eczema cohort. Next, we examined only fully vaccinated children for whom the variability in aluminum exposure was less, but it would be from vaccine product and not from under vaccination. The results were not significant for the eczema cohort, but they were significant for the no eczema cohort. That represents about 62% of the overall cohort. If we then examined, again, it's a separate analysis, adjusted for breastfeeding, there was only limited data from electronic health records on breastfeeding, only for about 13% of the cohort, so it's a much smaller cohort size. But with adjustment for breastfeeding, results were not significant for the eczema cohort and not significant for the no eczema cohort, although the point estimates were similar, but as I mentioned, the sample size was quite a bit smaller. Second to the last row, persistent asthma at 36 to 59 months of age. This was done with the thought that maybe wheezing at 24 to 35 months of age would represent viral-induced wheezing and not be true asthma. So in that analysis, looking at asthma diagnosed at a little bit older age, results were significant for both the eczema cohort and the no eczema cohort. And then finally, the last row is a negative control outcome of all-cause injury in emergency department and inpatient settings, 24 to 59 months of age. And as I explained, there should be no association with vaccine-associated aluminum, and it's a test for potential bias. And here the results are not significant for either cohort. All these analyses were adjusted for a number of covariates that are listed below. Next slide, please. So then how do we interpret these results? There was a small positive association between cumulative vaccine-associated aluminum before 24 months of age and persistent asthma at 24 to 59 months of age. There were positive findings for children with and without eczema. We did a number of secondary analyses. There were positive associations in some, but not all of these analyses. The study had a number of study strengths, which are listed here. Also, a number of study limitations, including that there was no data on dietary or environmental aluminum exposure. However, I'd put that limitation in the context that the American Academy of Pediatrics recently issued a report arguing that very little of ingested aluminum is absorbed, and so it may not have too much of an immunologic effect, in which case it's a little bit less of a study limitation. Additional limitations include that there's no data on social determinants of health. There, with all observational studies, is risk of unmeasured confounding. Some examples, there are many here because there are many asthma risk factors, but including family history of asthma, exposure to secondhand smoke. But we also need to keep in mind that they would need to be associated with both the exposure and the outcome to influence findings. In addition, and this is an important point, there could be antigen effects. And what I mean by that is it could be, if there's a positive association here, that it's not the aluminum within vaccines, but an antigen such as acellular pertussis that somehow influences immune response and subsequent allergy risk, and that we're detecting it through aluminum only because aluminum is a proxy for the antigens that come along with the aluminum. And as I would highlight, which I've mentioned several times so far today, this is the first step in a multi-step process. Next slide, please. So, changing gears a little bit, this is a figure that shows asthma prevalence among children less than 18 years of age in the United States, 1980 to 2020. This is based on National Health Interview Survey, so this is parent self-report of their child's asthma. And then you can see the y-axis is prevalence in percent, and then the x-axis is years. And then there are additional tick marks for when various vaccines were added to the schedule. All of these vaccines contain aluminum, with the exception of some Hib vaccines contain aluminum and some do not. And as you can see from the figure, asthma prevalence was rising in the US from 1980 to 1996. Again, this is in all kids aged less than 18 years of age. Then there was a gap where there was no data. And then rates were stable from about 2000 to 2010, and then have been decreasing since about 2010. So this is entirely ecologic, so we need to interpret this with all the caution that we would any ecologic data. But asthma prevalence in the U.S. does not appear to be rising alongside additional aluminum-containing vaccines added to the U.S. childhood immunization schedule. Next slide, please. So I mentioned further investigations of vaccine-associated aluminum and the risk of asthma. We'll hear from Dr. Anders Veed, who's going to present next on data from the Denmark National Database. In addition, there's a new study that's planned in the VSD. This study will have a larger cohort and longer follow-up time, although there is overlap between this cohort and the cohort in the study that I just presented. We're considering examining aluminum as a earlier exposure before 12 months of age, as opposed to the study that I just presented, which was 0 to 23 months of age. Examining eczema as a covariate and not stratified by eczema. And then the most important distinction between this new planned study in the VSD and the one I just presented was to examine asthma at a later age. We've had a number of consultations with colleagues both at the NIH and at CISA. And there's concern that I made reference to before that asthma diagnosed earlier may represent viral-induced wheezing and not true asthma. And so asthma diagnosed at a later age is more likely to represent true asthma. And so, again, this study would look at asthma at a later age, 60 through 84 months of age is what's been proposed. In addition, we have extensive conversations about additional considerations for other data sources which could help assess any relationship between vaccine-associated aluminum exposure and risk of subsequent asthma. Next slide, please. So, to try to put this area of study in a broader context, the totality of available evidence continues to support the safety of the routine childhood vaccination schedule. And existing federal safety surveillance systems are robust and responsive to concerns expressed by parents of young children. And I chose that word responsive very carefully because, again, the safety surveillance systems, they responded to the COVID pandemic. And here's an example of responding specifically to a call to action from the Institute of Medicine and essentially a call to action from parents to study this area. And then, as you can tell from the presentation so far, precipitated by the 2013 IOM report on the schedule, there's a new field of study that's being developed that's examining cumulative, repeated exposures to vaccines and vaccine ingredients, and, as recommended by the IOM report, examining long-term health outcomes. So I practice primary care pediatrics, and at the time of the issuance of the IOM report in 2013, if I had a parent who asked me, has the safety of the entire schedule been studied in the context of long-term health outcomes, I would need to say no. I would say there's a lot of supporting evidence that's supporting the safety of the schedule, but it hasn't been studied in exactly that way. But now I can say, yes, it is being studied in exactly that way, and can even convey to parents findings such as there appears to be no evidence that antigens in the childhood immunization schedule are associated with supplemental risk of infectious disease. There appears to be no evidence that the schedule as a whole is associated with increased risk of autoimmune disease, such as type 1 diabetes, and additional study is ongoing about any relationship between vaccine-associated aluminum and asthma risk. This was an unanticipated finding and has not been replicated. And then in conclusion, the benefits of vaccination strongly outweigh the known and potential risks. So I really appreciate the opportunity to present this to the ACIP today and look forward to providing continued updates in the future. I will next pass it over to Dr. Veed, and then we'll take questions after that. Thank you.
Yes, good afternoon. I'll present our preliminary results from our Danish evaluation of aluminum content in childhood vaccines and risk of asthma today for you. Next slide, please. So this is the study setting, the study setup. It's a nationwide cohort study. We include all children born from 2009 to 2016. We started the follow-up in the study in 2011, 1st of January, and ended it on the end of 2018. And similar to Dr. Daly's study, we looked at, we had follow-up from 2 to 5 years of age. And it's important for you to understand that all our exposure and outcome data are from nationwide registers that cover the complete population, and that we have easily and free universal healthcare in Denmark. And the study's cohort size that we operate with here is 470,000 children. Next slide, please. So this is a little about the Danish childhood vaccination schedule. It's not as extensive as many other countries. In the first year of life, we have the infant vaccines at 3, 5, and 12 months. That's a diphtheria, tetanus, pertussis, inactivated polio, hip shot, and a separate pneumococcal shot. 3 doses. Then at 15 months, we have MMR1 at 4 years, MMR2, and then a booster at 5 years, and then HPV at 12 years. And below you can see the aluminum content in the vaccines that we're using during the study period. And so for the DTP shot, for the majority of the study period, we used a formulation here from SSI, which had 1 microgram of aluminum hydroxide per shot. This was then changed in 2019 to Pentavac, which has only 1/3 of that aluminum content. However, we did have some production and supply issues intermittently in the study period, and that's why we're also seeing that we've used infant Rixhexa and Hexion when that was the case throughout the study period. They also have an hepatitis B part, and they have a little bit less aluminum content than the shot that we use most of the time. And then we've used Prevnar 7 and 13. You can see that the aluminum content for those shots also. Next slide, please. So here you can see the cumulative aluminum exposure that we are talking about in our study here. To your left, we have the box plots of cumulative aluminum content received through vaccines by age 2. All the numbers here are in micrograms. And from the box plots, you can see that the majority of the variation in our data, in our study here, is basically across birth cohorts. Within each birth cohort, you don't see a lot of variation. For example, in 2011, 10, 11, and 12, you can see that the percentiles overlap completely, which basically means that for 50% of the, at least for 50% of the children, they had the exact same aluminum exposure is the same as the medium. And at your right, you can see the actual numbers. And if to contextualize it a little bit to the US situation, For the birth year 2009, the median was 4.125 micrograms of aluminum by 2 years of age, and I think that's more or less the same as Dr. Daly had in his whole study, that median value. But as you can see in the later birth year, the exposure is almost half by the end there in 2016. Next slide, please. So how did we define the asthma outcome? We included, similar to Dr. Daly, both hospital diagnoses and prescriptions. For hospital contacts, we used ICD-10 codes, J45, J46, asthma and status asthmaticus, really severe asthma. We looked at both in and outpatient contacts. For prescriptions, we actually used a Danish validation study who looked at the positive predictive value and sensitivity of using different definitions of prescription use. And so we tried to balance towards having a high positive predictive value. And there we used inhaled corticosteroids, at least 2 prescriptions in the study period, short-acting beta agonist, at least 3, Montelukast, at least 2, and long-acting beta agonist, just 1 prescription. And for each of these criteria, that was enough to be classified as an asthma case in this study. We excluded everyone who had prescriptions or hospitalizations before study started at the age of 2. And then we used survival analysis, so analyzing the time to the first of the above events. Next slide, please. So these are our secondary outcomes we looked at. And this was sort of a data-driven approach, recognizing, as I just described, that we have different criteria for becoming an asthma case in our study. And also recognizing that these criteria are, of course, not mutually exclusive. So an asthma case could fulfill several of these criteria. And so this is just a data-driven cluster analysis, trying to sort of make some computational phenotypes of asthma in our study, some subcategories to dig a little bit deeper into in sub-analysis. And we found four clusters. The largest cluster, cluster 4, was primarily defined by the inhaled corticosteroids criteria, and for many also short-acting beta agonists. The second largest was more or less primarily defined by the short-acting beta agonist prescription criteria, and then we had 2 smaller clusters defined by hospitalization contacts and Montelukast. Next slide, please. So these are the descriptives for the cohort. As I mentioned, it was about 470,000 children. The column to your right, you can see sort of the overall descriptives for the cohort. First, according to birth year, you can see that, each birth year is approximately 60,000 plus or minus in Denmark. With respect to sex, slightly more boys than girls in our cohort. With respect to MMR vaccination status by 2 years of age, 86% had received their first MMR shot. And with respect to ethnicity, evaluated as the birth or the country of origin of the mother, 89% were born in Denmark of the mothers. All the children in our cohort were born themselves in Denmark. The other columns are categories of aluminum received through vaccines by the age of 2. You could say sort of the main takeaway here is if you look at the topmost row, the 0 micrograms of aluminum, these are the completely unvaccinated. So having not received any of the 6 shots in infancy that contains aluminum, we have very few of those, which is to be expected. Other than that, you can see that the different categories of aluminum received, they correlate quite strongly with the birth year. And that was sort of also what you could see when I showed you the box plots of aluminum exposure in our cohort by birth year. Next slide, please. And so these are our main results. The primary outcome, which was hospitalization contacts with asthma diagnosis or any of the different anti-asthma medication criteria. We had approximately 5,800 asthma cases using this definition. You can see here the hazard ratios of getting or fulfilling our asthma criteria throughout the follow-up according to aluminum received through vaccines by the age of 2. Here the reference category is the lowest category, but among those who received aluminum-containing vaccines. So less than 2.25 micrograms, but not completely unvaccinated. These are the ones with 0 micrograms. And what you can basically see is there's really no support for an association between aluminum received through the vaccines and development of asthma in this primary analysis. And these results are adjusted for sex, year of birth, maternal country of origin, and MMR vaccination status by age 2. Next slide, please. Here, it's a dose response analysis done in each birth year cohort. The dose response is per 1 microgram additional aluminum received through vaccines by the age of 2, and it's the primary asthma outcome. And again, as you can see, there is none of the birth cohorts is there really any strong support for an association between increasing amounts of aluminum received and the development of asthma defined using the primary outcome definition. Next slide, please. This is just then looking at the secondary outcome definitions from the data-driven cluster analysis I showed you. Here, I'm showing a comparison between the largest category of cumulative aluminum received, which is more than 3.375 micrograms by 2 years of age, compared to the reference category that I mentioned before. We're still talking about hazard ratios, but now according to development of asthma defined according to the different criteria here. Again, there's really no support for an association between aluminum received through vaccines and any of these data-driven ways of defining subcategories of asthma in our study. Next slide, please. The limitations. Yeah, so limited variability in cumulative aluminum received is of course a limitation, and of course the variability that we have in our data is strongly correlated with year of birth, which is a limitation. Of course, as Dr. Daly also mentioned, we don't really know if it's true persistent asthma or if it's wheeze in the youngest children. Next slide, please. But the takeaway of these preliminary results are there's really no support for an association between aluminum content received in vaccines and development of asthma by 5 years of age in Denmark. Next slide, please. There is no next slide. Okay, that was the last one. Thank you.
Thank you so much, Professor Veed. So this set of presentations is now open for questions and discussion. Dr. Chen.
Dr. Daly, thank you so much for the for walking us through all that complex information. I do have one question comment, and it might be just my naivete and understanding, but I think I understood that you are recognizing that viral-induced wheezing might represent some sort of confounding. And I guess what asthma brings to mind is my medical school teaching, so this might be wrong now, but RSV early on in life it might be associated with increased risk of asthma. We don't know why. It might be a host factor, And so the reason I bring that up is because was RSV incident medically attended visit or hospitalization looked at, or is that something that you're looking at in the future? Because that could also represent not just the risk for asthma, but also that opportunity for vaccination because they're being brought into a medical home. So that was my question.
Yeah, thanks, Dr. Chen. So there is a published definition of early severe bronchiolitis. That is bronchiolitis resulting in hospitalization within the first 12 months of life, and that is associated with subsequent risk of asthma, although we don't know kind of the directionality of that, meaning do kids who are asthma prone then just have that happen, or does that happen and then cause them increased risk of asthma? In either case, we examined that in this study as a covariate, and it was significantly associated with risk of asthma, but when included as a covariate, it didn't change the underlying findings of the study.
Dr. Fleming-Dutra, did you want to add anything?
If you would like me to. So again, this is Dr. Fleming-Dutra. I'm the co-lead of the maternal pediatric RSV work group. And I was just going to reference kind of in response to your second point, there has been a more recent observational study that was published, I believe, in the Lancet, the INSPIRE trial, that looked at the association of RSV infection in infancy and later childhood development of asthma. And it was a very well done observational study that actually showed not only is bronchiolitis and wheezing in early childhood associated with later childhood asthma, but infection, even in the absence of wheezing in infancy, is related to later life or later childhood development of asthma. It is an observational study, so causality cannot be established. But I will also add that the two products that you all are considering for prevention of RSV infection in infants or RSV disease in infants probably, we don't think will have a large impact on infection. And so if RSV infection is in that, we don't know, but if it's in the causal pathway to later life asthma development, the current products, nirsevimab and maternal vaccination, probably will not mitigate that risk. But a lot is to be known, and we don't know right now.
Thank you. Dr. Long?
In a placebo-controlled modivizumab study, which is a highly potent monoclonal antibody against RSV in the American Indian population that was published, showed us that the prevention of RSV did not alter the likelihood of persistent asthma. So I think that has been put to rest, except as a unmasker. If you're set up to have asthma, you may be more likely to wheeze with RSV, but RSV does not cause the proclivity for asthma. I think that's where we are right now.
Thank you. Ms. McNally?
Thank you. Dr. Daly, I assume that VSD allows you to screen for any children who would have renal conditions such that they would be excluded.
Ms. McNally, do you say renal conditions?
Yes, yes. Any renal diseases?
So, yes, and I may need to get back to you on details of sort of specific concerns that you have. I mean, I think that in this study, it's a large cohort. However, kids with complex chronic conditions were excluded from the analyses, but that's a small percentage, and that's based on something called the pediatric medical complexity algorithm. So, yes, we can detect it. It probably wouldn't influence the study findings here. Are there specific renal diseases that you were inquiring about that could sort of influence whatever we observed here?
So just thinking about the fact that aluminum is excreted by the renal system, so that was really kind of at the crux of my question.
Yeah, no, thanks. Thanks for that additional context. I mean, I think, we need to recognize that aluminum has been used in vaccines for more than 80 years, and there are several different forms of aluminum, hydroxide and phosphate, and that they're important immunogens. They enhance the immune response. They're there explicitly because they make vaccines work better. But even so, there are things that are not known about exactly the sort of pharmacokinetics and biologic activity of aluminum used as an adjuvant. There are studies that show that after vaccination, serum aluminum levels don't change, hair aluminum levels don't change. But then that doesn't exactly tell you sort of how that relates to how aluminum is excreted from the kidneys. And there is some work that I'm not terribly familiar with around when aluminum is used in parenteral nutrition. So essentially it's IV nutrition. But that's in extraordinarily high doses compared to what is injected in vaccines. So I'm not sure that's really comparable. So, your comment is sort of just a reason for us to also acknowledge some things that we don't know about the metabolism of aluminum. But what we do know is that probably any sort of underlying renal disease doesn't influence the immunogenic effects of aluminum. And so probably is not explaining any association that we see here.
That's helpful. And
Okay.
just as a follow-up question, as a parent, I'm trying to think through this. What impact, if any, would infant formulas have in this sort of evaluation?
Yeah, thanks so much for that. So, Ms. McNally, what's interesting context here is that breast milk contains aluminum and infant formula contains aluminum. And so one of the questions that I have in all of this is, does the aluminum that's taken in by breast milk or by formula cause any immunologic effect? And I don't have an answer to that other than to say that the thought is that very little of that is absorbed. So we can think about it a couple different ways. Does it relate to the association that we saw? Possible, but unlikely if it's not absorbed. But do we need to know more about this as we pursue this hypothesis? Definitely yes. I might see if Dr. Buddy Creech is on and if there's anything that he would add, because we've talked a little bit about this over the past couple of years. Dr. Creech?
Yeah, this is Buddy. Thanks for that, Matt. I think this level of inquiry is exactly right. There are environmental exposures that may impact overall aluminum exposures. It's hard to understand how those are differential in some of the analyses that were done. And then I think we have to recognize that different aluminum adjuvants do have different pharmacokinetic and pharmacodynamic properties, right? So aluminum phosphate dissolves more rapidly than aluminum hydroxide. So while we don't know that the immunologic effects of different alum preps would be substantially different, we do know that the pharmacokinetic and dissolution characteristics, the charge on the surface of the molecules, the shape of the molecules, all of those may have an influence.
That's really helpful. And I just want to thank you for doing this work, because I think this is so important and truly does help improve vaccine confidence.
Thank you. May I ask a very specific question, which is actually looking at Professor Veed's data, and thank you very much for presenting. I think it's incredibly helpful to have a complementary data source, and that one that has, you have such beautiful data in Denmark. You have the full cohort and all of the full information, so it's really helpful to have that complementary view. But one of the things I noted was the secular trend in exposure. And so that made me wonder whether or not there were any differences in the VSD data, or whether the study design accounted for calendar year or any other secular or seasonal trends.
Yeah, thanks, Dr. Lee. So down in the fine print on both the primary analysis slide and the secondary analysis slide, these analyses were all adjusted for calendar year and calendar month. And so, adjusted for example, a baby born in March of 2013, it's the year plus the month. And that's a fine level of adjustment, but we felt like that was necessary because of risk of secular trends, including of viral respiratory infections that could influence risk of asthma. So, and the cohort was big enough that we could make that fine a degree of adjustment, and that adjustment did not change the underlying association that we observed.
Dr. Lair?
I'd like to second Ms. McNally's comment and say thank you. As a practitioner with a large vaccine-hesitant population, I often get questions about the risks, and now I have more data to comment and say that they actually are studying these. So I appreciate the CDC and you're moving forward with these studies. Thank you.
Thank you. Any additional questions? Dr. Paling.
I want to echo my thanks for your doing the study and being very deliberate in the process, and then also making sure that you share and explain what you do and do not understand. I also very much appreciate the future directions and do believe this session during the ACIP is particularly helpful, and hope that as more information becomes available, that can be included in the future. Thank you.
Thank you. Dr. Sanchez? No? Okay. I don't see any other hands raised, so I also just want to add my thanks for, number one, pursuing this work on behalf of the public. It's really important work and really hard to do, and recognize all of the challenges with the study designs and the limitations that we have. But just to say it out loud, I mean, the totality of the data we just reviewed is actually really reassuring. And even though we're talking about where else aluminum can come from, breast milk, the environment, other places, what I'm taking away from this is looking at both studies together, that it doesn't seem like there is an association that I am concerned about in the moment. I'm also very intrigued by the findings from diabetes, that it looked protective. So it gives you a little bit of pause to say it definitely deserves further work. And again, really appreciate the investment and the time and the care that is spent with regard to ensuring that our vaccination program is as safe as possible for our entire childhood population. So thank you. And with that, I think we're going to take a 5-minute break. And thank you, Professor Reed, for presenting from Denmark, whatever time it is there. We really appreciate your time and your effort on this work as well. Thank you again.